Sternum is anterior, right? Rib cage is formed anteriorly by sternum on anterolaterally, right? Both anteriorly and laterally it is formed by ribs. Posteriorly it is ribs and thoracic vertebra. So that is the boundary of thoracic wall. Thoracic wall. The fascia lining the inner aspect of the bone is called as endothoracic fascia. Outside we have skin, superficial fascia, muscle layer. We have intercostal space filling the intercostal space, right? The space between the adjacent rib is called as intercostal space, which is filled by intercostal muscles, right? Deep to this, there is a fascia encircling the thorax that is called as endothoracic fascia. So you have a thoracic inlet and a thoracic outlet. Thoracic inlet and thoracic inlet. Inlet and outlet. Inlet is above, outlet is below. Is it clear? Now, true ribs. 1 to 7 ribs are true, since it is articulating directly with the sternum. 8, 9, 10 are false ribs, but it is attached to the sternum by means of cartilage. So it is false rib. 11 and 12 are floating rib. It doesn't have any articulation. This is 11, this is 12. This classification you should remember. The parts of the sternum are manubrium sternum, body of sternum and zippy sternum. Zippy sternum, diffy sternum. Can you able to see this? The transverse diameter is larger and the posterior diameter is smaller in adult, whereas in infants both AP diameter and transverse diameter is more or less same. Because what type of respiration we have? Thoraco-abdominal or abdominothoracic for us? For humans, abdominothoracic. For us, for infants it is thoraco-abdominal. Since the cavity is more or less same, for them it is circular, more or less transverse diameter, and the AP diameter is same for infants. The parts of the sternum are body of sternum, zippy sternum, zippy sternum. So what you see here is the manubrium sternum. Am I right? What is this rib? First rib, which is articulating with the first thoracic vertebra. You connect all these three. That is the boundary of thoracic inlet. Manubrium sternum, first rib, first thoracic vertebra. That is called as thoracic inlet. Thoracic inlet. Thoracic inlet. At this level, you should remember a fascia called as Simpson's fascia, which is extending from the transverse process of C7. This is T1, right? Cervical vertebra is C1 to C7. Next is thoracic C1. Here you will be having lungs. Lungs is covered by pleura. Extending from C7 towards the first rib, you get a fascia extending down in a triangular shape. That fascia is called as Simpson's fascia. That fascia is called as Simpson's fascia, which is hooked above by subclavian artery. The extent of the fascia is from C7 to first rib, not thoracic vertebra. This is lung. Am I right? So you get a fascia at this level. You cannot see a lung on the neck. Am I right? Whenever you inspire, there is no puffing of your neck, lungs into the neck. It is prevented by a fascia at the level of the apex of the lung. That fascia is Simpson's fascia. Here, that will prevent the lungs coming. If there is no fascia, whenever you inspire or expire, you should see your apex of the lung here, right? But we're not seeing it. It's only because of the fascia which is preventing. The attachment of this fascia is extending from the neck C7 to T1 since to the first rib. So below first rib is the lung. So the lung is not coming up. The artery related is subclavian artery. First intercostal muscle is external intercostal muscle. External intercostal muscle, which is downwards. Am I right? It is downwards. Next muscle is internal intercostal. Downwards laterally. This is downwards medially. Am I right? Like this, it is coming downwards medially towards the sternum. This is downwards laterally away from the sternum. We are talking about the intercostal muscle. Next, Once you cut open the sternum, inside there are muscle. The muscle is transversus thoracis. Transversus, transversus thoracis. Now you see this is the sternum on the inner surface. On what purpose sternum is used? It is very superficial, right? So if you want any bone marrow biopsy, you can easily aspirate it. Thing to be remembered is behind the manubrium sternum is the arch of aorta. So you should not put your needle above the burn space. This is the supraclavicular space, otherwise called burn space. But if not, accidentally, it can lodge on arch of aorta, which is the major blood vessel arising from left ventricle. So you may have table death. So that's the reason we always prefer from the body of the sternum. Okay, for any bone marrow aspiration cytology. Okay. On either side of the sternum is internal thoracic artery. Internal thoracic artery. I said along with the blood supply of the breast. Am I right? Internal thoracic artery, which is running on either side of the sternum. I said intercostal space. Am I right? These spaces are called as intercostal space. What is the content we saw in the intercostal space? Muscles we see. External, internal, transversus, which are expression for inspiration and expiration. But the intercostal space, apart from the muscle, it contains intercostal nerve and intercostal nerve. The content vein structures, VAN, vein, artery and nerve. The content of the intercostal space are, apart from the muscle, it has vein, artery and nerve. Intercostal vein, intercostal artery and intercostal nerve. Running on either side. It is anterior intercostal artery and the anterior plane. Posteriorly it is posterior intercostal artery. If you take intercostal space, I said 3 to 6 ribs are true ribs. That classification is depending upon the articulation. Okay. One more classification is depending up. These are typical rib. Typical rib is 3 to 6. What is remaining? 1, 2, 8, 9, 10, 11, 12 are atypical. These are atypical ribs. They doesn't have uniform features. Normally rib should, 3 to 8. Normally all the ribs should have same features. Am I right? Any bone, any thoracic vertebra will have some difference over here and there, right? That we call it as atypical and typical. So if the features of the ribs are typical, it is called typical rib. 3 to 8. 1, 2, 11, 12 are atypical. They doesn't fall under that category. This you have to remember. Is it clear? True rib, false rib, floating rib. That classification you should remember. Typical, atypical. 3 to 8 are typical. 1 to 11, 12 are atypical. This you forget. I said intercostal space. Am I right? Intercostal space. Between two ribs, you have to calculate. Totally, there are 11 intercostal space, of which 3 to 6 are typical. 3 to 6 are typical. Others are atypical. Why so? I'll tell. You remember this alone. How many intercostal space? 11. 3 to 6 are typical. Each intercostal space contain what? Muscle, vein, artery, nerve. So anterior intercostal artery. Can you able to see on the picture 1, 2, 3, 4, 5, 6, right? I said how many intercostal space? 11, right? Now you see on the picture, it is arising from subclavian artery for the upper two spaces. All other spaces, it is arising from the internal thoracic artery. Am I right? I said on either side of the sternum, what is the artery running? Internal thoracic artery. Up to which level? 6. Internal thoracic artery is dividing into superior epigastric and musculophrenic artery. So 7, 8, 9, 10 anterior intercostal artery arises from musculophrenic artery. Musculophrenic artery. This is posterior intercostal artery, right? Arch of aorta continues as descending thoracic aorta on the thorax, which continues by piercing the diaphragm, enters the abdomen as abdominal aorta. Abdominal aorta. Anterior intercostal arteries are anterior. They arise from internal thoracic artery. Posterior is posterior towards the thoracic wall. So what is the main source here? One larger blood vessel behind, in front of the vertebra is descending thoracic aorta. They ramify laterally as posterior intercostal artery. I said 11 intercostal space. 3 to 11 are arising from descending thoracic aorta. 1 and 2 arises from superior intercostal artery. This is a branch of subclavian artery. Upper two spaces from subclavian, other spaces from descending thoracic aorta. You understand, right? Anterior internal thoracic artery that divides into superior epigastric artery, enters the rectus sheath into the abdomen for anastomosis. Musculophrenic, as the name indicates, phrenic is diaphragm. It ends on diaphragm, on the superior surface of diaphragm. If there is a posterior intercostal artery, there should be posterior intercostal vein. Now you see on this, how many veins? Number it 1 to 11. Subcostal is 12. Okay. This is right side. This is left side. Number 1 drains into, directly into, where it drains? Right brachiocephalic vein. Right brachiocephalic vein. 2, 3, 4 is uniting to form, right? 1, 2, 3 is not separate. It unite to form right superior intercostal vein, which drains on acegos vein. 6, 7, 8, 9, 10, 11, 12. Again, it drains on acegos vein. On the left side, 1 drains into left brachiocephalic vein. 2, 3, 4 unite to form similar to right superior intercostal vein, which drains on left brachiocephalic vein. Am I right? Closely observe the picture. This picture tells you all the drainage. Accessory hemiacegos 5, 6, 7, 8. If not, you can say accessory hemiacegos is formed by. Am I right? You can use this terminology also. Am I right? What are this 5, 6, 7, 8? Those are posterior intercostal vein. So the formation of accessory hemiacegos vein is by the union of 5, 6, 7, 8 posterior intercostal vein. 9, 10, 11 on left side. Be specific. This is left. This is very important because we have acegos on right side, hemiacegos and accessory on left side. Hemiacegos formation is by union of 9, 10, 11 posterior intercostal. You understand, right? So that completes artery vein of the intercostal space. Next is the intercostal nerve. 3 to 6 are typical intercostal. There are 11 intercostal space. We have 11 nerves, of which 3 to 6 are typical because it is supplying only thorax. T1 is going to brachial plexus, right? T2 is coming to the arm along with the axilla. Already we discussed intercostobrachial. T7, T8, T9, T10, all other will supply the intercostal space as well as the anterior abdominal wall skin. It is supplying two areas. Am I right? T1, T2, upper limb. T7 to T12, abdomen along with the thoracic. So it is atypical. That's all. Okay. This is how it looks on the intercostal space, right? On the surface of, you get a groove called as costal groove. The groove is called as costal groove. That the vein touches artery and nerve. Anterior intercostal vein, posterior intercostal vein, anterior intercostal artery, posterior intercostal artery, intercostal nerve. Present on the lower border, near the lower border of the rib. So during pleural tapping, what we should do is, we should not put the needle on the lower edge. Your needle should be only on the upper edge of the needle during pleural tapping. Is it clear? Intercostal nerve damage, drainage. This is how we have to put the drainage, right? The needle should not endanger the neurovascular bundle. Okay, so the stuff again, intercostal nerve. Have you heard of Herbis zoster? This is Herbis. Herbis zoster. Why it occurs? It occurs on the ganglia, right? The ganglia, what has been present on the, these are the ganglia present on the course of intercostal nerve, right? virus will be lodged on the course of the intercostal nerve. So it is, the pattern is very similar, right? The nerve is here the spinal cord is present. The nerve comes from posterior to anterior. It follows the course of the nerve. That is very typical. That is the herpes zoster. Next, the internal thoracic artery. What is the terminal branch of internal thoracic artery? It is dividing as musculophrenic and it arises from subclavian artery. What would be the importance of this internal thoracic artery? It can be used for arterial graft. You can take a bit of the artery. It is replaced over the coronary artery, which has been thrombolized or necrosed. Okay. Apart from this, you can have a very venous graft from the lower limb. You have to take a vein from the great saphenous vein. Only thing, you have to reverse the lumen once you take. Being vein, we have valves inside it, right? Artery doesn't have any valve. But nowadays, apart from a venous graft, the arterial graft are better, because here the peculiar feature is the internal thoracic artery has only elastic fibers, similar to the coronary artery. Again, coronary arteries are not end artery. They keep on ramifying as the age advances. Okay. So this you're clear, right? Intercostal space you're clear. What are all the content, right? Nerve, muscle, 3 muscle, 1 nerve, anterior intercostal artery from where they are coming, posterior intercostal artery from where they are coming, which are all typical, which are all atypical. Why true rib? Why false rib? How many ribs in number? Which are all typical intercostal nerve, which are all atypical. Whenever you read anterior artery, posterior artery, from where they are coming, that flow chart you should remember. It is given on your textbook. Okay. What is mediastinum? Define it. The space between the space between the two lungs is called as mediastinum. The space between two lungs is called as mediastinum. Right? This is manubrium sternum. This is body of sternum. This is xiphisternum. Right? If you cut an area between the manubrium and the body, which is resting posteriorly on T4, right? So this is called angle of Lewis. Angle of Lewis. T4 corresponds to angle of Lewis. Angle of Lewis. This is superior. This is inferior. Inferior mediastinum is divided into anterior, middle, posterior. Can you able to see this? Space between two lungs is mediastinum. It is divided into superior and inferior. What is separating superior and inferior? Angle of Lewis. Inferior is further divided into anterior, middle and posterior. The structures of the thorax are present on mediastinum, except lungs, which is present outside. All other neurovascular structures are present along with the heart, great blood vessel, arch of aorta, ascending aorta, descending aorta, brachiocephalic vein, thymus, vagus nerve, phrenic nerve. They are all present on mediastinum. What is the covering of the lung? Pleura. So what are all the layers of pleura? Visceral pleura and parietal pleura. Visceral pleura is adherent to the organ. You cannot peel off and take it. It is adherent to the. Now you should know what is pulmonary ligament. So the visceral pleura and the parietal pleura continue. This is called root of the lung, right? Trachea is dividing into right bronchus and left bronchus. Pulmonary artery is entering the lung. Pulmonary vein is coming out of the lung. Am I right? Those are the pedicles which holds the lung, which the other part of the body. They are the connections, right? To the heart, it is connected by pulmonary artery and pulmonary vein. To the trachea, it is connected by bronchial tree. So what we call it as root of the lung. That area is root. That opening is root. At that side, you get evagination of the pleura called as pulmonary ligament, which contains only lymphatics and loose areolar tissue. It contains lymphatics and loose areolar tissue. Okay. So if this is the root of the lung, you get inferior pulmonary vein on the lowermost part. Okay. So what would be the function of the inferior pulmonary vein? Inferior pulmonary vein is lower down, right? Whenever you inspire, there acts as a potential space for the filling of the blood on the inferior pulmonary vein. That's the reason why pulmonary ligament is present on the lung. What are the two types of pleura? Visceral and parietal. Can you able to see this green color area? This one, what I am shading, that ligament is pulmonary ligament. Pulmonary ligament. What is pleural cavity? The cavity between the parietal pleura and visceral pleura is called as pleural cavity. Again, the types of the pleura are cervical, right? If it is covering, if this is the lungs, if it is covering the upper part, it is cervical. If it is covering anterior surface, costal. If it is covering inferior surface, diaphragmatic. If it is covering medial surface, mediastinal. Right? This is costal, cervical. This fascia we already finished, right? Suprapleural membrane. Costal pleura is covering anterior surface of the lung. Diaphragmatic surface. This is diaphragm, but it is not so, right? It is covered by pleura. Diaphragmatic pleura. Medial surface of the lung is mediastinal pleura. This is important. Recesses are important. Recess is called as spaces, right? You get costo-mediastinal recess, costo-diaphragmatic recess, costo-mediastinal. This is costo-mediastinal. This is costo-diaphragmatic. You see which is lower down at the edge, costo-diaphragmatic. Costo-mediastinal is towards the medial surface. As the name indicates, mediastinum, which is medial surface. So that pleura is costo-mediastinal pleura along the anterior margin of the pleural reflection. If you see the right lung and left lung, you get a notch here. Am I right? On the left lung, that notch is called as cardiac notch, which is extending between the 4th to 6th cardiac costal cartilage. 4th to 6th costal cartilage, which is the area of maximum cardiac dullness. Area of cardiac dullness is between 4th to 6th costal cartilage on left side only. 7th rib is the longest rib. 9th rib is the most oblique rib. This you have to remember, this theory. 7th rib is longest rib. 9th rib is the most oblique rib. Recess, how many recess? 2 recess. Costo-mediastinal, costo-diaphragmatic. What is the maximum area of cardiac dullness? 4th to 6th costal cartilage. Nerve supply you have to remember. Okay. Which is pain sensitive? Parietal pleura is somatic nerve, so it is pain sensitive. Whereas the pulmonary pleura is supplied by sympathetic plexus. Right? Sorry, it is parasympathetic. Sorry, sympathetic. T2 is sympathetic, so it is pain. Pain from pleura. If there is any pleurisy, you get some pain. Right? That pain is perceived from which pleura? Parietal pleura. Pulmonary pleura is pain insensitive. Can you see on the picture? Fusion on the left side, right? This is full of translucent shadow. Up to this, it is translucent. You will get a transopaque area. Am I right? Collection of fluid. Am I right? That represents the costo-diaphragmatic recess is obliterated. Costo-mediastinal. Both the recesses should be present here, right? This is costo-diaphragmatic. Here it is costo-mediastinal. Both the recesses are obliterated. Can you able to see on the picture? Again, pleural effusion. Can you able to see here? You cannot see the cardiac notch properly. Proceeding with the lungs. How many lungs we have? 2. Right, left. Right lung is upper lobe, middle lobe, lower lobe. Left lung is upper lobe, middle lobe. Right lung is divided into upper lobe and middle lobe by means of one fissure. The fissure is oblique fissure. This fissure is oblique fissure. The extent of the oblique fissure is from C7 to T10. This level you should remember. C7 to T10. And this fissure is transverse fissure, which divides the upper lobe into upper and lower. So how many lobes on right lung? 3. On the left lung, 2. Here how many fissures? Two fissure here it is. And as we already discussed, additional feature on the this border of the lung is anterior border. This border is anterior border. This border is posterior border. This border is anterior. This is posterior. So which border is notched border? Which lung? Left lung. That notch is called as cardiac notch. This surface of the lung is costal surface. This surface is costal surface. This surface is mediastinal surface. This surface is inferior surface. This surface is inferior surface. Can you able to see what is related to the ribs is costal surface. Costal surface. What is related to the root? This area is root. What ligament you expect here? Pulmonary ligament. This is structures on the root. What are all the structures you can see? Remember, right lung as trachea divides into right bronchi and left bronchi. Right bronchi enters right lung, left bronchi enters left lung. So that right bronchi, after entering into the right lung, it divides into two bronchus, epartial bronchus and hypartial bronchus, two bronchus. Trachea, bronchi, again two, there is only one bronchi on the left side. That is the difference between right lung and left lung. Trachea divides into right bronchi and left bronchi. Right bronchi enters the substance of the lung by dividing into epartial, arterial and hyparterial, epartial and hyparterial. What I want you to remember is what are all the structures root. You see the picture, you get superior pulmonary vein, inferior pulmonary vein, and two bronchus. Am I right? If there are two bronchus, that lung is right lung. If there is only one bronchi, it is left lung. If it is only one bronchi, it is left lung. Is it clear? This is left lung where you get only one bronchi. This is one principal bronchi. An arrangement, you see the structure, pulmonary artery, bronchus, vein. Am I right? Pulmonary artery, bronchus, vein from above downwards. If you take right lung, epartial, what is this? Pulmonary artery. This is bronchus. This is pulmonary vein. Here four structures are present. Epartial bronchus, pulmonary artery, hypartial bronchus, pulmonary vein. Can you able to see the difference? 1, 1, 2, 3, right? Additionally, you have to divide this bronchi into additionally epartial. This you have to replace by hypartial. You understand, right? Here there are four structures from above downwards. Here how many structures? Three structures. Since right lung has two bronchus, primary principal bronchi, after entering the lung, it is dividing into epartial and hypartial. Here it is not dividing, it is only one bronchus below the artery. Here above the artery one bronchus, below the one artery bronchus you have to add. This is very important when you go for MCQ. Structures present on the right lung from above downwards are on this sequence you have to remember. Is it clear? There should not be any change. Azygos lobe. Sometimes, remember on the medial surface, the azygos vein is related to the right lung. Sometimes a part of the lung tissue will encircle the azygos vein. That is called as lobe of azygos. That is called lobe of azygos. Azygos lobe. Can you able to see this? Azygos lobe. Bronchopulmonary segments are 10 in number for each lung. Am I right? Apical, anterior, posterior, medial, lateral, superior, posterior basal, medial basal, lateral basal, anterior basal will be inside. Okay, there are 10 bronchopulmonary segment on both the lung, right? Can you able to see? Up to this, it is upper lobe. This is transverse fissure. This is oblique fissure. This is lower lobe, upper lobe, middle lobe, lower lobe. Here it is upper, that black line is the oblique fissure extending from C7 to T9. This is cardiac dullness entering by costal cartilage 4 to 6. Here 5 segments, here 5 segments. So totally how many segments? Each lung is 10. If you take only one segment, you concentrate on this area alone. Each part, bronchopulmonary segment is nothing but part of the lung aerated by tertiary bronchi. Bronchi divides into primary, secondary, tertiary, alveolar units, alveoli, thereby gaseous exchanges takes place. Part of the lung which is aerated by tertiary bronchi is called as bronchopulmonary segment. Along with the bronchopulmonary segment, you get bronchial artery and pulmonary artery along with the bronchi. So what are all the structures are present inside bronchi, bronchial artery and pulmonary artery? Now you see this area, right? Two intervals, that red color structure, right? I am putting an arrow, right? That we call it as intersegmental plane. Intersegmental plane, where you get the running of pulmonary vein. So pulmonary vein runs on intersegmental planes. It is not accompanying terminal. This is very important for surgical resection of the lung during lobectomy. This is a case question. That's why I'm repeating. Remember, this is one part of the lung. That one unit is a part of the lung, which is aerated by tertiary bronchi, which is accompanied by bronchial artery and pulmonary artery. So how many structures are present in one unit? 3 structures. Adjacent structures are separated by intersegmental plane. On the intersegmental plane, a vein is running. The vein is pulmonary vein. Pulmonary vein. You understand, right? So we resect lobectomy is very specific, right? If there is only which part of the lung is prone for tuberculosis? Mostly upper lobe. Why so? What is Pancoast tumor? I said posterior intercostal artery on the posterior aspect, right? If there is any dilatation of the posterior descending thoracic aorta, you get engorgement of the arteries on the posterior aspect that produces some notch on the inner surface of the rib. That is called Pancoast tumor. Tuberculosis is why common, means more blood supply. Abundant blood supply is present on the apex, so the Mycobacterium tuberculosis is very fond of an oxygenated blood. It can survive well. That's the reason why the upper lobe is very common. So during resection, we have to follow the intersegmental plane during lobectomy. Okay. This is a picture of lung collapse. I think these are the directions for drainage of the fluids from the. This is how we have to position the patient. Next is pericardium. What is pericardium? Outer covering of the lung is pleura. Outer covering of the heart is pericardium. So what are the layers of pericardium? Fibrous and fibrous is the outer layer. It is first divided into totally two. Inner layer is further divided into two. This is number 1. Together, this is number 2. That is divided into 5. What you should remember is of the heart is below, base of the heart is above. Just reverse on the pericardium. Base is below, apex is above. That you should remember. First difference. And between the two pericardium is pericardial cavity. The space is called as pericardial cavity. We get some spaces within the the great vessels of the heart, that we call it as sinus of pericardium. Sinus of pericardium. Now you see this is ascending aorta, this is pulmonary trunk. Am I right? Posteriorly it is pulmonary vein. So between this you get a space that is called as transverse sinus. That sinus is called as transverse sinus. Now you see this space, this sinus we finished, right? 1, 2, 3. between the great blood vessels of the heart, there are some spaces called as sinus due to the invagination of the pericardium, that is called as sinus. There are two sinus. First sinus is transverse sinus. Second sinus is oblique sinus. Transverse sinus, the boundary is anteriorly it is bounded by ascending aorta and pulmonary trunk, posteriorly by superior vena cava. Is it clear? Oblique sinus is bounded by, these are all pulmonary veins. How many pulmonary veins are present on the heart? 4. 2 superior, right? This is superior, this is inferior. This is superior, this is inferior. This is superior, this is inferior. One, this is right side, this is left side. So 2 superior pulmonary vein, one on right and left. 2 inferior pulmonary vein, one on right and the left. So the space between this area is called as oblique sinus. Again, this nerve supply is important for MCQ. Fibrous and parietal layer of serous pericardium are supplied by branches from phrenic nerve C3, C4 and C5 fiber, the root value. Visceral layer is supplied by T4 fiber, which is a part of sympathetic system. Part of sympathetic system. Up to this, you're clear, right? So, what are all the sinus? Transverse and oblique. Transverse and oblique. Heart is situated on which mediastinum? Middle mediastinum. Heart is situated on middle mediastinum. Can you able to see this? It is between the two lungs, encircled by pericardium. Encircled by pericardium. Now we'll proceed with the external features. There are 4 borders of the heart. This border is right border. This border is inferior border. This border is left border. Superior border is hidden by blood vessel. Borders. How many? 4. Right, left, inferior, superior is hidden one. Now I will proceed with the surface. This is S1, sternocostal surface. Sternocostal. This is inferior. Base otherwise superior. Base is otherwise superior. Left surface. S2. Okay. On this you can see S1, S2, S3, S4. Inferior and superior. Totally how many surface? 4. How many surface? 4. Now you identify the chambers of the heart. This chamber is right atrium. Right atrium. This chamber is right ventricle. This chamber is left ventricle. Which chamber is missing? Right atrium. This is right atrium. This is right atrium. This is right ventricle. This is left ventricle. Which is missing? Left atrium, which can be seen only on the superior surface. This is left atrium. So base is formed by left atrium only. Left atrium only. This part of the heart is called as apex. Which chamber is forming the apex? Left ventricle only. Left ventricle only. Base is formed by left atrium only. Now what is this surface I said? Sternocostal surface. Anterior is otherwise called sternocostal surface, formed by right atrium, right ventricle, left ventricle. Am I right? Right atrium, right ventricle, left ventricle, sternocostal surface. Am I right? Apex is formed by which chamber? Left ventricle. Base is formed by left atrium only. Am I right? Next. This is inferior surface, right? So this is right ventricle, this is left ventricle. So inferior surface is formed by right ventricle and left ventricle. What is this surface? Left surface is formed by left ventricle only. Left ventricle. Any doubts on this? This is very easy. This one picture will tell you everything. How many borders? Superior border, right border, left border, inferior border. 4 borders. How many surface? Four surface. Sternocostal surface, I can see three chambers. Right atrium, right ventricle, left ventricle. Inferior surface, I can see two chambers. Right ventricle, left ventricle. Superior surface, base, I can see only one chamber. Left atrium. Apex, I can see only one chamber. Left ventricle. You understand, right? Now you see, there is a groove here, right? Separating right atrium and right ventricle. That is called coronary sulcus. That is called coronary sulcus. Coronary sulcus. Again, you see two ventricles are separated by a line here. Am I right? That is called interventricular groove. Interventricular groove. It is anterior or posterior? Posterior. So this is posterior interventricular groove, which is present between the right ventricle and left ventricle. Again, there is one more groove here, which is present between the right ventricle and left. In general, you can say right ventricle and left ventricle is separated anteriorly by anterior interventricular groove. Am I right? Right? Same ventricle are separated posteriorly by posterior interventricular groove. You understand, right? Interior of right atrium. Two things you remember. This is fossa ovalis. This is limbus fossa ovalis. Fossa ovalis and limbus fossa ovalis. These are the remnants of the embryology. This is septum primum. This is septum secundum. Septum primum, septum secundum. Septum primum and septum secundum. Hello, na class that can kuputta. Septum primum and this is septum secundum. Septum primum and septum secundum. And you get the opening of coronary sinus. Remember, this is SVC. Okay, SVC. This is IVC. Yes, all the deoxygenated blood from the body will be poured into vena cava. Right? So this is superior. This is inferior. Apart from this, vein of the heart is coronary sinus. That is opening on right atrium. Coronary sinus. The valve guarding there, it is called as Sebacean valve. The valve, there should not be any backflow of the blood once it has been reached into the heart, right? That is prevented by a valve at the site of, this is the opening and the valve of coronary sinus called as Sebacean valve. It is called Sebacean valve. Sebacean valve. Sit and read this slowly. This one picture will tell you everything. Slowly you read. Okay, it will take some 10 to 15 minutes. Because something is lodged on this, right? On each groove, you can see an artery, a vein, artery, and a vein. Am I right? That we'll discuss. This chamber is right ventricle. Right ventricle. Two parts of the right ventricle are inflowing part and outflowing part, which are separated by supraventricular crest. Supraventricular crest. Supraventricular crest. What is the valve between right atrium and right ventricle? Tricuspid valve. Tricuspid valve. The component of the valve are a fibrous ring. Fibrous ring. Attached to the fibrous ring, you will be having the cusp. Cusp is connected by cauda tendineae. Cauda tendineae. Cauda tendineae is attached to the papillary muscle. This papillary muscle is attached to the wall of the ventricle. You understand? These are the components of the valve. Fibrous ring. Next is cusp, tricusp. So it is 1, 2, 3. Cauda tendineae. Papillary muscle. Papillary. Okay. Inflowing part, outflowing part divided by supraventricular. You see, this is the right ventricle, this is left ventricle, which is round. This is semicircular, this is more or less round. Because from right ventricle, what is arising? Pulmonary artery. From left ventricle, what is arising? Aorta. So more pressure will be present on ventricle. Left ventricle, since it is to give the maximum blood supply to the body. So that's the reason why the musculature access of embryology, it is very strong. Okay. Blood supply of the heart is by means of right and left coronary artery. Right and left coronary artery. So this is right atrium, this is right ventricle, this is left ventricle, this is coronary sulcus. Coronary sulcus. This is the anterior intraventricular groove. Anterior. What is this artery which is descending down? Principal artery is right coronary and left coronary. Remember, ascending aorta continues as arch of aorta. Arch of aorta continues as descending thoracic aorta. What you should remember is ascending aorta at this level. Coronary artery arises from aortic sinus. Right coronary artery arises from anterior aortic sinus. Left aortic sinus give rise to left coronary artery. Can you able to see this? These are the aortic sinus which are present on the ascending aorta. This you should remember. Right coronary artery arises from anterior aortic sinus and left coronary artery arises from posterior aortic sinus. Can you able to see this one? This is this artery is anterior intraventricular artery. The name of the ventricular groove. So the artery is intraventricular artery. So right coronary artery is larged on coronary sulcus. What does coronary artery largest? Right coronary artery. Right coronary artery. What does anterior intraventricular groove largest? Anterior interventricular. Same name. Anterior intraventricular groove is present between right ventricle and left ventricle, which largest anterior intraventricular. This is the previously we call it as artery of widow, right? LDA, right? Common artery of infarctus. This one only. Clinically, what you elicit on an MI patient is earlier it was artery of widow. Now the terminology has been removed. We are not supposed to use it no more. LAD. This is the commonest infarct during an coronary angiogram. Okay. Descending branch, anterior intraventricular artery. If there is an anterior intraventricular artery, there should be posterior intraventricular. What is the name of this groove? Coronary artery is larged on coronary sulcus. Anterior intraventricular artery is larged on anterior intraventricular groove. Posterior intraventricular groove largest posterior intraventricular artery. Posterior intraventricular groove is present between right ventricle and left ventricle. Anterior ventricular groove is present between right ventricle and left ventricle anteriorly. Coronary sulcus is present between right atrium and right ventricle. You understand up to this, right? The groove is present between what two chambers? What does it largest? You should remember. So far, I have enumerated coronary sulcus, anterior intraventricular groove, posterior ventricular groove, three arteries: right coronary artery, anterior intraventricular artery, posterior intraventricular artery. So there should be one more terminology you understand. What is coronary dominance? This will be asked in MCQ. Okay. Most of the part, the posterior intraventricular artery arises from the right side. 75%. If so, it is coronary dominance. Most of us are coronary dominant. This is the vein. The vein of the heart is coronary sinus. It opens on which chamber? Right atrium. What is the valve at the side? Sebacean valve. The valve is Sebacean valve. This is the summary. You slowly look over the branches and the origin. Okay. What we now discussed is given on this. Now supply of the heart. Superficial cardiac plexus from the superior cervical ganglion and lower 2 or 3 cranial nerves. Okay, so there are two types of cardiac plexus. Superficial give branches to the deep right coronary artery. Deep is further divided into right and left. Deep branches is divided into, as I said, right and left. The situation of the right is in front of pulmonary artery. This is behind this. What is the location of the deep cardiac plexus? Okay, and where it supplies. Mostly it is supplying the chambers of the heart and the blood vessel, but the location you should remember. Deep cardiac plexus is lies in front of pulmonary artery. This is behind the pulmonary artery. Is it clear? One is in front, one is behind the pulmonary arteries. Ascending aorta, arch of aorta, descending thoracic aorta. Arch of aorta gives us what are all the branches? Brachiocephalic, left common carotid, left subclavian. What is the angle T4 called as? Angle of Lewis. So the origin of arch of aorta on the right side and the end of the arch of aorta on the left side are same, T4. On the right side, T4, it is originating as arch from the ascending. On the left side, it is ending at the level of T4 as arch, then it continues downwards as descending thoracic aorta. Right? This is how an arteriogram of the angiogram of the blood vessels look. Right? This is an aortic aneurysm picture. Aortic aneurysm. This we already discussed, right? Descending thoracic aorta. What you should remember is, I forgot to tell you regarding the blood supply of the lung. What is the blood supply of lung you expect? Bronchial artery, pulmonary artery or pulmonary vein are not major supply. They are entering and leaving. That's all. Main blood supply is how many lungs you said? Right lung, left lung. For the right lung, it arises from the third posterior intercostal artery. For the left side, 2, 3, 4 intercostal artery. One more thing is, there is only one bronchial artery on the right side, whereas two bronchial artery on the left side. That is the major difference. Right lung has only one bronchial artery, left side has two. What other structure you expect in the thorax apart from heart and lungs? Esophagus? Yes. You should know the constriction. Esophagus is nothing but the continuous of pharynx, which is a muscular organ, continues into the abdomen as stomach, which is posterior to the descending thoracic aorta. Posterior to descending thoracic aorta is esophagus. Posterior to trachea first. Am I right? It is first posterior to trachea, then it is posterior to the heart. Am I right? So sometimes you get compression of this left ventricle into esophagus, called as Harkness syndrome. The syndrome is called as Harkness syndrome. Compression of left atrium. If there is any left atrial failure, normally failure of the chamber is left atrium. Am I right? If that failure occurs, it goes and compresses the esophagus. Dysphagia. The symptom might be on the cardiac symptom, but the patient will have dysphagia. You have to elicit whether it is a pathology of GIT or purely in cardiac symptom. Important duct of the lymph duct is thoracic duct. Right? See on this picture, this is the cisterna chyli. All the lymph from the body. What is this word? Thoracic? Thoracic vertebra. Embedded in front of the thoracic vertebra is cisterna chyli. Some beaded green color structure, right? Don't concentrate on the blue one. It is azygos vein. You concentrate on the green structures alone. Right? That is called as thoracic duct. It ascends above. Crosses from right to left. It ascends above. Crosses from left to right. And it opens on the interval between the left internal jugular vein and left subclavian vein. This is left internal jugular vein and left subclavian vein. The area of drainage of thoracic duct contains lymph, but ultimately all the lymph should be poured into a venous channel, right? It opens on the neck. It is in front of the thoracic vertebra. It ascends up to the thorax by passing through the aortic opening of the diaphragm. Then it enters into the posterior mediastinum. Still it is posterior on the right side, but I am telling the drainage on the left side. So it is crossing from right to left, going and ending on the angle between the left internal jugular vein and left subclavian vein. I think this we already finished, right? Hemiazygos, accessory azygos, right? How accessory azygos is formed? 5, 6, 7, 8, left posterior intercostal vein. Next, 9, 10, 11, left posterior intercostal vein forms hemiazygos. Azygos vein formation is 1, 2. Subcostal vein and lumbar vein. Remember, anything subcostal is T12. What is related to the 12th rib is, it might be nerve, artery, vein. Subcostal is T12. Normally, chest X-ray is PA view. It is not AP. Always chest X-ray is PA view. This is trans-opaque shadow. This is translucent. Air can pass through, it is translucent. If the air doesn't pass through, it is trans-opaque. Read this. Heart sound, I didn't tell you, right? I'll tell the location of the heart very easily, how to remember it, okay? Prime Minister, take alcohol. This mnemonic have you heard of? Prime Minister, take alcohol. Okay. Left second intercostal space. Left fifth intercostal space. Second, fifth. Over xiphisternum. Second, right intercostal space. This is the area of auscultation. It is not corresponding to the anatomical location of the valve. That you be clear. If you open this area, you cannot see the valve. That is entirely different surface marking. These are the areas where the heart sounds are better heard over the surface of the heart. Number 1, pulmonary heart sound is better heard on left second intercostal space. Prime Minister. P. M. Mitral heart sound is best heard on left fifth intercostal space. Take. T. Tricuspid sound is better heard over xiphisternum. Alcohol. A. Aortic valve. Aortic sound is better heard on right second intercostal space, all close to the sternum, because intercostal space is extending from anterior to posterior, but the heart sound are close to the sternum. That one word you add up for everything. Okay, that completes heart sounds. With this, thorax is over. Okay, very briefly, intercostal space are important. What we first read, the intercostal space is important. Lung, bronchopulmonary segment, lobes, blood supply, how many lobes and fissure, pleura nerve supply, heart nerve supply, chambers, coronary artery from where they are arising, what is thoracic duct, hemiazygos, azygos vein. That's all. Beyond that, they won't ask anything. Okay, these are all very, very important. Okay, anything if I left, you make it up and tell it to me. We'll clarify on the next class. Okay. What is the structure accompanying posterior interventricular artery? Middle cardiac vein. The answer is middle cardiac vein. A thoracic surgeon removed right middle lobar secondary bronchus along with the lung tissue from a 17-year-old smoker with lung cancer. Which of the following bronchopulmonary segment must have contained cancerous tissue? Right middle lobar. How many segments are present in middle lobar? The answer is medial and lateral. Medial and lateral. 37-year-old patient with severe chest pain, shortness of breath, congestive heart failure was admitted to local hospital. His coronary angiogram reveals a thrombosis in circumflex branch of left coronary artery. Which of the following condition would have resulted from the blockage? It is on left coronary artery. Which valve on left side? Mitral valve insufficiency. 50-year-old patient recently suffered a myocardial infarction in the area of the apex of the heart. The occlusion by atherosclerosis is seen in the following arteries. Area of apex. Area of supply of apex is anterior interventricular. Anterior interventricular artery. So with this, we are completing today's session. Okay.